Good morning, good afternoon, and good evening. Welcome to you all for this very special webinar. I'm Mukta Sandhu, Senior Scientific Education Manager, representing Geislich Pharma Switzerland headquarters. Why did I say it's a special webinar? Because we have a modern day legend with us, Professor Istvan Urban, and he's going to talk about vertical, hard and soft augmentation in anterior region, which is a very demanded and hot topic by the clinicians. They really want to know, and I'm really happy that he's going to talk about this. He does not need any introductions. We are going to straight into the webinar. I would like to just point out that please write down all your questions in the question box, and we will address them at the end of the webinar, and Professor Urban will answer them live. What a great opportunity. Please do not lose out on that. So enjoy the presentation. I'm really excited to hear him. And Professor Urban, the stage is all yours. Thank you.
Hi, I'm István Urban, and today I'd like to talk to you about vertical hard and soft tissue reconstruction of the anterior maxilla. I think this is a great topic, and basically there's a lot of patients who need treatment like this for different types of reasons, and many of them are young. And here you can see one patient who has an advanced defect. You can see the bone, you can see the teeth. And so that was quite a bit of things we had to do to reconstruct this. And that's what I want to discuss. Problem number one. Many times when you have a vertical defect, you have a facial asymmetry. And so this is like a patient who really has even a kind of like an orthodontic problem, but we're going to solve that with one single guided bone regeneration surgery. And so this type of patients, that's another patient who we treated over 20 years ago. And I would have to say that this is very predictable. And I think this is timeless because it served until, unfortunately, the end of the life of the patient, which was, more than a decade. So this type of patients, they have a no lip support, and they look older. They need to have like a removable prosthesis to support, back the face or the bone graft. And here you can see after one surgery, there's a lot of gain horizontally, a lot of gain vertically. You still have to do little things when you place the implants, but I just want to show you the face, how much improvement you give the patient to the face. So, you can see here another examples, asymmetrical lip, very unhappy patients. Some of them are like partially edentulous for decades. And so you want to reconstruct the bone, the soft tissue, and the face at the same time. And, many times are coming with a distorted tissue like this patient, who you can see that you have previous graft particles, a previous failed bone graft. That means there was not much of a vestibule, there was scar tissue, and you are even making this worse because you have to do the suborbicularis preparation, and now this is a demanding procedure to reconstruct. Not only the bone is done now, but also the soft tissue, and to be able to place the teeth. Based on the article that I just presented, and we published in 2016, we proposed that there are 4 types of anterior maxilla, depending on the vestibular depth and the height of the defect and the flexibility of the flap. So scar tissue, no scar tissue. And I want to do like a little bit of information on this. You can see the facial asymmetry here. You can also see the advanced vertical defect, which is really advanced. Half of the maxilla is missing. Patient had an accident like 20 years ago, and there was some attempt to reconstruct. They removed some of the chin, and you have to reconstruct the left mandible. You have to reconstruct basically a 6 centimeter length of a defect, which is a 15 millimeter high, and there's very little bone that you can take from. And I don't think there is any other technique on the world that you can do an intraoral bone graft on a patient like this. And the reason is that when you do any bone blocks, it's basically not enough for this, and it's a very small volume. The block is the smallest volume. You put a piece of block into a bone meal, your volume grows. Okay, so please look at this, that I'm going to do the bone graft, and I only can harvest a little bit of bone from here. From the chin, there's not much left. Maybe you can scrape some. The left ramus, which there is some, you don't want to touch because you will do the lower left one. And so, scar tissue, there is no vestibule. Sinus wall is broken. Defect is gigantic. And you need 50% of the biomaterial and 50% of the autogenous bone. So you cannot do this very, predictably with 100% biomaterial. So then that's why you need to take some bone. And in this case, we're going to use a microdose of a growth factor. So you can see here, we're fixating perforated PTFE membranes. They need it for the growth factor, any growth factors. You need a perforated PTFE or perforated membrane. You can see that there is a large amount of particles I'm able to place, and the volume is so big because I'm particulating the entire graft. And now you can see that we even protected with an outside layer of some inorganic bovine bone mineral. The microdose of bone morphogenetic protein will corticalize this in a few months. And so it's 6 centimeters long. It is 15 millimeter high, 1 centimeter wide, and the flap is very, very short. Now we can have a plan how we're going to close this. And I actually put in the first suture here after 7 minutes. What we have done here with different steps, such as the periosteoplasty, such as then the debundling, then the suborbicularis preparation. This is the periosteoplasty when you go underneath the scar tissue. You go underneath the scar tissue. But remember that anatomically, and I'm going to cover that, there is some things that you could damage, and you don't want to do that. So it's very, very important how delicate you're going to advance this flap. And now you can see 7 minutes later, the flap is advanced. And you can see that the incision line is not really going too much palatinal, but it's the suborbicularis preparation that is, really coming down. So now provisionalization is another issue. It was not very easy, but we did manage the provisional. Now here's the bone graft. We're going to take out the membranes, and you can see that now it's beautifully bleeding. It is corticalizing because of BMP. The inorganic bovine bone mineral and the autogenous bone is perfectly incorporated with each other. So now we can place the implants. And you can see the face of the patient improved tremendously. And this picture was done only after the bone graft with a surgical guide in there. And it's almost perfect already. So I'm going to come back to this case. I'm going to show you a little bit of the soft tissue manipulation after this. I'm going to cover very briefly the most advanced cases. This is a class 2, which is there's no vestibule and the patient has no scar tissue. That's easier. I love that. Okay, there's no vestibule, so you have a very short flap. A very short flap is not enough to close these grafts. Face is asymmetrical, so you really, not only vertical, but you horizontally have to support the lip. And so, in this type of cases, when there's no vestibule, we're doing the extended safety flap, which is a larger flap, about 4 teeth away. We're going to do the vertical incision. There's a reason for that. I took this bone in 10 minutes. I basically made a little flap, took with a little trephine, put it into the bone meal, and it's on. So basically, harvesting the bone here and mixing it with the graft and particulating it is very, very easy. And it adapts to the defect. Now we're going to do, because we have done the extended safety flap, we're going to do the popular shift that can help closing these flaps, around the teeth. And this is the popular shift. You close the vertical incision, and there's another thing we did, and that's the suborbicularis preparation. As you can see from the lip, the tissue is coming straight down. And that's the only way you can elongate the flap well enough so you're going to be able to cover such a defect, and you should have an uneventful healing. So guided bone regeneration is the least amount of complication, has the least amount of complication for this type of procedure. Now, here's a schematic diagram of the suborbicularis preparation. Difficult to understand, I know. But let's see if I can explain this a little bit better. So here's the defect. This is the graft. This is horizontally the graft. Okay, so that is for the lip support very important. And now, there was a soft tissue defect, and now we reconstructed the soft tissues. Lip support is reconstructed. Smile is reconstructed. And patient is very happy because she was like this for over a decade. And yeah, so basically, this is the suborbicularis preparation. Now, what you can see here is that really the tissue is flat. This is on a specimen. But I want to show you a little bit anatomically what you have to do. You have to be very, very careful. On the left side, you can see after the suborbicularis preparation, the orbicularis muscle on a specimen that is not damaged. Okay? So basically, we're very, very superficial. And on the right side, you can see the infraorbital nerve. With these patients, the defect is so big, the infraorbital nerve becomes very, very close. And you can see here the branches of the infraorbital nerve. So basically what we have done is everything is so careful, so superficial, so blunt, that we do not want to damage any of this. And I think it's one of the complications for the anterior maxillary defect, quite frequently, that when you cut with the blade, deep, shallow, deep, all these things, but the defect is so big, you get too close to the nerve and you're going to damage the nerve. So no blade to advance the flap. The blade is just opening the door, and then you're going to advance the flap bluntly. And you can see here another patient who basically had so many bone grafts that you can see that the nerve, look at the CT scan, the nerve is completely exposed. They removed all the bone from the side of the mandible. And we get many of these patients, so you can do a scraper, or you can do things like very careful. The good thing is I don't have to harvest anything in one piece. I can use a particulated bone graft. And so this type of patients, again, there is no vestibule. This patient also has scar tissue. It's a class 4. Flap is so short, and you don't want to make it so shorter. So basically, we're going to cut here in the middle of the keratinized tissue, which is in the middle of the crest here, and we're not going to distort. It's going to come to the middle of the crest, because all we're going to do is the trick. That we're going to take this suborbicularis, take this flap, flatten down, and the incision line goes back, basically almost to the same place. And here you can see I'm using I don't use a lot of tenting screws. In these cases, I use in the middle one, but this was too short because I only had the 10 millimeters, and so basically I even covered this one because it's more than 10 millimeters, this defect. Scar tissue, again, anorganic bovine bone mineral, autogenous bone, mixed. Bone harvesting was basically from the other side. It still took 10 minutes. Microdose of the BMP2 for the extreme defect, we like it. It's just a microdose. It's like basically 4 milligrams, which is not giving swelling, but it makes it very fast. Now this one, and I do that a lot, in the middle with a PTFE membrane, a vertical augmentation, on the side, 2 sausage type of bone graft. I combine them all the time. Why would I do another PTFE when I can do this now with a collagen? So I'm going to add the bone graft, I pin the collagen, I stretch the collagen, and this is the sausage technique in combination with a vertical ridge augmentation. But the flap is so short, right? So now we're going to do again a very careful incision through the periosteum. The periosteum here is white. That means it's fibrotic. in the middle is more than white because there's a lot of graft particles in there. That is scar tissue. And now the first step is I'm going to go through the periosteum super careful. Then I'm going to go under the scar tissue. Then I'm going to rotate my blade, I debundle. And then I'm going to do the stretch for the suborbicularis. You see I'm going to go almost into the lip area. And it's flat. The incision line is basically the same place. It's just flat. I'm going to have to reconstruct this, which I'm going to talk about. Okay, so as you can see here, maybe I have a picture how that heals. I didn't have a picture here. Anyway, you can see this. On the right side, you can see the suborbicularis. On the left side, you can see the papilla shift. This is how we treat patients. And so the fourth type of defect, which I just showed you, has no vestibule, has scar tissue, and foreign body incorporation. For this type of patients, even if it looks good outside, inside is the problem. And these are the steps we're going to do, such as the periosteoplasty, such as the suborbicularis preparation to get bone from here and there. And then you can see here, the left picture is the suborbicularis preparation. The middle picture is the papilla shift and the suborbicularis. The left one was the periosteoplasty, by the way. Okay, there's not much of a vestibule left. We're going to reconstruct that. And then we're going to finalize the patient. I think it's acceptable. From that X-ray, I could talk a lot more. But anyway, you can see the lip is now, which was completely asymmetrical, and the smile is symmetrical. And so that's basically the principles of the surgery. Okay, now, there's another thing. You don't always need a vestibular, reconstruction after a bone graft. Unfortunately, this poor patient had an accident and she's too young to get implants. And so anyway, we did a socket graft for the patient. And then she was, a couple of years later, she grew. And I had to use the implants which were sticking outside of the bone. Now, why 3 implants? Well, we try to do teeth for the patient, not necessarily a bridge, sometimes a bridge, sometimes single teeth, but that makes it much more difficult. And here I have a lot of keratinized tissue, I had a lot of vestibule, and so here, when after the bone graft, I got the bone graft, I'm going to do a soft tissue thickening surgery, I'm going to do a papillary soft tissue graft, but I'm not going to do a vestibular extension surgery because this keratinized tissue is good enough, the vestibule is good enough, I don't have to do the suborbicularis preparation. I don't have to do the suborbicularis preparation, and there was enough tissue, and the tissue was beautiful, I don't have to do anything else, but I do need always a connective tissue graft. There is a closed connective tissue graft. Here I'm putting it together like a mosaic. This is good for a bridge, but it's not good for single implants. Okay, so I need to use a different origin, so tissue graft in the middle. And that's what we call the iceberg connective tissue graft, the inter-implant iceberg connective tissue graft. So now you can see here, again, I'm using 7-0 resorbable sutures. I like the monofilament. I'm making it so stable that even if, let's say, the flap opens up, which is not going to happen, it will survive. Good. It's a partial thickness flap. Now, I took a little tuberosity. Be careful with the tuberosity. It grows over, and 10 years later, the tuberosity arrives first, then the patient. So, the tuberosity should be used only for the triangle of the papilla. And I keep using 2 surgical guides, a digital and an analog guide. And the analog guide also shows me the papilla. Is the position good enough? If it's good, now we're going to close. And you can see here, I'm slightly distorting, but there's a rebounce. If you distort not more than 3-4 millimeters, it's going to rebounce. I'm using the micro loop sutures, which we do all the time for the vertical incisions. And that's it. So this is what we've done. This is the double iceberg. This is when the tissue is maturing. This is how the smile is improving. And this is how the tissue became exactly like nothing happened. And this patient has 3 teeth, which are natural teeth. In our second book, you can see a chapter, how to reconstruct the bone and the soft tissue with preserving the mucogingival junction. But unfortunately, most of your patients will need a vestibular extension. These patients are coming asymmetrical. They have a defect. They had failures. There is no keratinized tissue, so you have to reconstruct it. You have to plan to reconstruct the vestibule. And so the first step is going to be, now we're going to do the flap. You can see pieces of old graft particles. You really want to perforate that. The harvesting of the bone is easiest for guided bone regeneration. Now you can use here a PTFE perforated. You could use a titanium mesh too. However, that has a little bit more problems in terms of exposure. Anyway, I'm doing a very blunt preparation. We have a new study, randomized clinical trial, shows that you do need a collagen membrane because you're going to get more bone. Okay, so do you want to cover a perforated PTFE, a perforated titanium mesh with a collagen membrane? According to an RCT, yes, you want to cover because you will get more soft tissue, less soft tissue ingrowth under the membrane. And you can see here this patient didn't have an vestibule, so there is a there's a suborbicularis preparation. But I want to show you this. I showed you the because look at that. So careful that nothing was damaged. You could see little branches of the arteries. It's all blunt. It's all very careful. Good. So once we have this, okay, we're going to place the implants. And this patient is going to have 2 implants. He's going to have a bridge. Okay, prosthetically, space-wise, this was very difficult case. So forget about, doing single teeth for a patient like this. Anyway, here it is. We use 2 surgical guides. This is the anatomical guide, partially guided only, and we got it right. But there's another problem here. The soft tissue is too thin. You can see also the papilla has, a little bit receding. So we're going to do the first problem, 2 problems. One is the vestibule. The second one is the thickness. So first we take care of the thickness. This is what we call the safe track. Partial thickness flap. I'm taking which I don't like to take, like a big piece of soft tissue from the palate, including the epithelium, but it's a very good quality of soft tissue. I like the epithelialized graft, but this is a big one and another one on the top. And I'm checking, the position. This is the microsuture. That's again, a blunt, preparation. It's good. Now we have this. The next problem is going to be that we have no vestibule. So we did a strip graft. And we're doing a soft tissue graft in one more place. The strip graft, we're going to do a mucograft to collect the cells. I'll talk more about that. Okay, so that's like bone graft, implant placement, mini sausage, thickening, and this. Okay, that's what we call the garage. Now we're going to push down the papilla. When sliding in the connective tissue that I just showed you. Okay, you can see here, what was it before? It was good thick tissue, but it was all distorted tissue, and with a strip graft, which is so thin that it doesn't give you much disturbance to the patient, and the mucograft, we're able to reconstruct the vestibule now, which I think is the biggest step to me in the last 20 years in soft tissue grafting for the vestibule. Now you can also see that unfortunately this patient has had many years of orthodontics, and this is the best they could get out. So prosthetically not very easy. Our prosthodontist, Dr. Forster, and Dr. Nicola Pietrabone, and Mr. Nicola Pietrabone, they did a very good job. I think, they curved it back. Obviously not perfectly symmetrical, but I think, patient was very happy with this. Her face is perfectly symmetrical. Smile is perfectly symmetrical. Very beautiful smile. Very stable bone. Why? Because at the time of implant placement, we covered it with a little bit of the biomaterial, mini autogenous chips, which we call the mini sausage. And when the patient came, was asymmetrical, the smile, the teeth, and all that. Okay, so there we go. Now, the strip graft. Okay, look at the patient, the cleft patient. After the cleft surgery, I reconstructed the whole thing, but there's like suborbicularis preparation, complete loss of the vestibule. What can you do? You can do a free gingival graft. There's no way I'm going to do a free gingival graft. You can do an open connective tissue graft. It's much better, but there's no way anymore I'm going to do an open connective tissue graft. You can do multiple strip grafts. That's like a free gingival graft. It's a very good technique because it doesn't give you too much of a pain. Dr. Han and Takei was developing this. But you can do the strip in combination with the mucograft, what I just showed you. which is going to be, this patient already has soft tissue thickening. We do a modified apically positioned flap, and here we take the strip from the palate. Is a 2 millimeter free gingival graft, which is the palate is so, the wound is so little that it doesn't hurt. So we're gonna put it from keratinized tissue. Then we leave the rest with the mucograft. But do you need the mucograft? Yes. How do I know? Well, number one, because of the experience, you don't want to leave the wound open. Plus, there is a randomized clinical trial in medicine using this type of collagen for wound healing. And it shows that in a diabetic patient, if there is a wound and you don't cover it with the mucograft, there is about 10% of the healing. If you cover it with mucograft, there's almost 90, like close to 100% of healing. So really the healing becomes super, super fast. Okay, this is how we suture it. This is how the patient comes. This is the soft tissue graft. This is the maturation. And this is 10 years later when we had to do something with the restoration. We removed it, and look at this, in 10 years, we still have, and the tissue is much more beautiful than if I would have done a palatinal, like bone, like soft tissue graft, gingival graft. This I call timeless. It looks like it's timeless. So let's look at this patient. I just showed it to you before. Okay, we had the bone, we had the bone graft, we got the bone, but now we have such a tremendous amount of soft tissue defect that normally the oral maxillofacial surgeons, they take a skin graft, because they're not going to do, it's not such a big free gingival graft you can do. They can do a skin graft or like take the whole palate out, but we're not going to do that. We're going to take a strip, and the strip is going to be 14 centimeters long, but 2 millimeters thin. It doesn't matter how long it is. It is so narrow that the patient is not experiencing pain in the palate. How do I know? We did the study. Out of 20 patients, 19 reported no pain for the palate. So we do the modified apically positioned flap. Means modified. We keep it thick. There's a first zone on top of the implant because that was a connective tissue graft for thickening in the anterior zone. Then we go closer to the periosteum to make it attached. Then we're going to stake the tissue, which was the subo, and rotate it back and suture it up towards the lip. Without this, these implants would be in very, very bad quality tissue. Without this, you would be super invasive with some other type of soft tissue graft. And so now we're going to suture it up, bend it back. We do the T-mattress suture for this. Then I'm going to take the strip. Again, 14 centimeters, only 2 millimeters wide in one piece. And I got lucky because it was just the perfect size. And now I'm going to take it from the keratinized tissue of the central incisor, connect it. I use a 6 or 7 sutures, just the connection at the beginning. Then I'm going to do cross matrices to go around. Cross matrices to hold this down, to go around. Pull it up, and it's perfect length to the back. Okay, so that's it. That's what is the strip doing? It doesn't allow the mucosa to come back, and it provides cells into the collagen matrix, which is absorbing cells from the palate, absorbing cells from here, and that is how you're gonna get keratinized tissue. As you can see here, with a very simple procedure, we're able to reconstruct the vestibule, the keratinized tissue after this beautiful bone graft. Okay, so there's a series of studies, also histological study, showing that this is keratinized tissue, even the keratin proteins. Good, we know this. There's even a little, cartoon type of thing here about discussing how we had, thought about this. Okay, so I want to go through the steps. And there's an article which we published in together with one of my mentors, Dr. Joseph Kahn, one of the fathers of aesthetic implants. Anyway, there's a defect, young patient, there's the bone graft, step 1. This is going to be the safe track. Good, got the bone graft, collagen membrane on the top, not much of a distortion, but some distortion. Not the incision line, a little bit here for safety. How many implants? 2, but I placed 3. How many guides? 2, normally 1. I have a digital guide, analog guide. Why? Because now I'm doing the papillary graft. This is the inter-implant iceberg. One palate, 2 mini tuberosity. But then I had a little bit of an issue, to reconstruct this. So let me see if I can fast forward this here. Okay, so we've seen, and now we're going to take the strip from the facial if there is enough gingival. Why do we do that? Because of the color. And today we know that if you compare the color from the palate, which we did objectively, palatinal color versus buccal color is day and night. Okay, after this, basically the color is almost a complete perfect match. Texture can be improved. So here I am suturing. I'm going to fast forward this again because of time. Take another one. And then at the end, we place the micrograft. Okay, here we go. I did another little surface graft in the middle to get better texture. Anyway, so this is a micrografted window. Why? Because in the middle, I have 2 mini strips for texture. And you can see the color is getting there, the final restoration, and the Janos Gross did it, 3 crowns on 3 implants, and this is how the patient came. These are the steps that we do. There are cases when the soft tissue defect is so big that the iceberg connective tissue graft is not enough, then we're going to combine it with the garage connective tissue graft. In this case, where you have 2 implants, there's some distortion mucogingival junction, there's absolutely like a negative papilla. Implants are, I would say, questionable, acceptable level. You accepted them. We didn't place them, obviously. First, we did just open it up, evaluate the implant, clean the surface, use the iceberg. Okay, iceberg improved it, but not enough. This patient needs a strip, and I'm going to fast forward because I just showed it. Okay, strip is coming from the buccal as much as possible to avoid the palate because of color. Okay, once we got the strip on, then in the previous iceberg, we're going to make an incision, and there we slide in another connective tissue, and that's the garage connective tissue, which is an article that you can read in the International Journal of Periodontics and Restorative Dentistry. You can see this. I'm taking a little piece of tuberosity. Why? Because it's the triangle of the papilla, basically. Deepitalize it, slide it into the garage. It looks like a garage, but I have to close the door. Okay, and I'm going to do another little partial thickness flap and closing the door. Okay, we use this all the time. And this makes a big difference, and you will see. Okay, so start closing, and almost perfectly closed. Good. I put in the mucograft. This is the final outcome, and you can see here the 2 implants, which had absolutely no papilla, now has pretty much a perfect papilla. Absolutely no papilla before and after. And patient is very, very happy with this. Okay, so we have patient who had like gigantic defect, removed the bottom of the nose. The 2 side of the bone does not meet. Okay, there's like a 3 centimeter defect. Good. We do guided bone regeneration on this. Okay, so we've done it. Okay, this is the membrane, suborbicularis preparation. Good. Collagen membrane on the top. We went back, remove the membrane, and that will be, maybe in the first time ever, I've never seen this, a connection with guided bone regeneration with 2 bone segments, which is much more than a vertical defect, biologically speaking. And now we can place the implants. Okay, the implants are in. There are 3 implants in an area where there was no bone whatsoever. But it needs a big piece of connective tissue graft, or alternatively, you can use a collagen material such as the FibroGuide. This patient did a lot, so we did a normal CTG. Then we went and did the apically positioned flap, and here, and just show you the strip from the palate and the combination with the buccal. Why? Okay, this is the double strip. In our book, there is this chapter called the double strip. The palatinal strip is holding it upstairs. The buccal strip, which I take from here and from here, is going to improve the healing, the speed of the healing, and the color of the tissue. Okay, according to our study, the buccal strip makes no aesthetic problem to the donor side, nor any, much of a disturbance. Patient needed a little touch of a soft tissue graft, so I did a garage in the central incisor. Then we placed the collagen matrix, which is huge collagen matrix. Okay, we closed the garage door. Take the collagen matrix, dry. You do it dry, okay? Use a 6-0, suture it up there. I even put another one in between in the two apical one, which maybe not absolutely needed, but I like to, once I do it, why don't I do it right? Cross mattress sutures are holding it. Good. Okay, so now this is healing. Implants are in. Final restoration. Please look at the color of the tissue and the texture of the tissue. Okay, there was like a gigantic defect, a real lot of distortion when the patient came already. Lip support is intact. There was no bone whatsoever. Okay, so 3 ways to do it. The big case is you do the safe track. Technical track is the autogenous track. Forget about it. Fast track is for single teeth or maxing 2 teeth defects. The safe track is about 15 months to do all the little work you do. Okay, obviously you have to do workup for the patient like this. You have to clean it up, quit smoking, things like that. That's a sausage in the anterior maxilla. Good. Then we place the implants, the 2 surgical guides. Then we do the iceberg, okay, which is a palatinal, again a palatinal in the middle, and a tuberosity, palatinal. It's a deepitalized connective tissue graft and palate. It's a good source for a basic thickening. And for the tip of the papilla, we do the iceberg. That's actually a different, case, but I'm just demonstrating here again the iceberg. Good. There is a distortion. We do the strip, but this is a palatinal strip because the patient didn't have enough gingiva. Not every patient is going to have enough gingiva to take from the buccal. I tried to take it from the buccal. I couldn't. You can look at the papilla. And these are 3 implants. Yeah, that's a beautiful picture, but let's look at this in another type of, a little bit more higher up. Bone is, we did the mini sausage, bone is absolutely perfect around the implants. Some veneers, okay, before and after. And I'm going to show this in another picture when we're going to go up and check out the color, okay? Good. Look at this patient. This patient is a good vestibule, very beautiful tissue, but in the middle, the tissue is not beautiful. So even I can do this with or without distorting, but it doesn't really matter because I need to do a strip graft for sure. The patient had an accident, there's a damage. There's a graft. There's the bone. Ice cube means I take one piece, then I slice it, becomes the iceberg. Papillary guide. Buccal strip. I couldn't find much, so I took it from here. Then I took it from here. Good. Strip. Provisionalization. Look at the 3 implants, and the papilla is growing in between them. And please look at the keratinized tissue. It's getting more and more beautiful. After the restoration, you can see that this is the perfect color match with 3 implants, which I know it sounds like, why would you do 3 implants? Why? Because the patient is forcing, the patient is going to have, single teeth. Obviously, it's much better. Not always you can do it. This is about 8 years later. Not the best picture, but anyway, look at the bone. Bone is perfect with the mini sausage, even though it's 3 bone. These implants are suffocating in bone, and I think this is a timeless regeneration. Okay, lip support was not there. Smile is there. I don't think you can tell that this patient has implants, not even a bone graft, not even implants. You would say nice crowns. So, yeah, this patient is coming like this. It's not about the type of the bone graft, okay? It's just, it could be GBR, could be whatever, but it's a failure. Started with a single teeth, 2 teeth, and now 3 teeth defect. And this is how the patient came. I had to clean it out. Now there's the defect, the bone graft. The bone graft. Let's look at the bone graft in like 30 seconds. There's not much of a vestibule. Okay, we need a strip graft for sure. Okay, you want to make sure that this works. So I think a suborbicularis would really make sure that it's going to work. Also, I want to mention that GBR, we can do much bigger, like wider bone that usually, the cortical cancellous blocks, for example, they're not as wide, or, it's very difficult to get this width. Plus, now this was the subo, the collagen membrane closure. Good. We have the bone. Good. We have the closed connective tissue, 3 pieces of connective tissue here. It's good, but could be better. Good. This is the strip. 2 strips from the buckle. And the garage, because I think she needed still some more connective tissue. This connective tissue, there's a double connective tissue, comes down here. Yep, the other one is on the picture on the top. Okay, this is the anatomical guide. I'm putting in the double connective tissue graft to increase this. So then I close the garage. Okay, 2 buccal strip, good color. The collagen matrix, minimally invasive surgery with the garage. Look at that. Look at how it's healing. That's going to shrink to its position within 3 months. And after that, you provisionalize, you finalize. And Dr. Janos Gross did the final work. I think he did a fabulous job. And please look how happy this patient was. She wasn't very happy when she came. This is a bridge. This is the standard of care, I would say, to do. Okay. Anyway, this is how the patient came. And Mr. Araki from Japan, did the porcelain beautifully. Good. I want to show you something. So here's the defect before, here's the defect after. So you place the implant. I didn't tell you, didn't show pictures of the mini sausage. What is that? You place your implants. You do maybe 20% somatogenous chips on the implants and a layer of bios, and then stretch out the membrane like a sausage, pin it down, you leave those pins in, and this will provide you much more stability of the bone. Okay, so this one, it's not bad. I mean, it's good, it's acceptable, but actually the color of the tissue does not look bad. So labial versus palatial strip is a study we do, and it's in progress, and with Dr. Tavelli, and you can see here, beautiful. I think it's beautiful color. It's good color. Look at this one. That's a palatine color. Over time, the palate is aging poorly. Okay, so it's good. Okay, both cases are beautiful. I think both cases are very successful. Both patients are very happy with this. But if you look at an honest picture, one is white, the other one is red, and that's big difference. Good. I want to talk a little bit about, interproximal bone loss. This patient has an interproximal bone loss, no buccal bone, no palatinal bone. We do a bone graft. Here we used the PDGF growth factor on the root, after root planing. We did the PDGF on somatogenous chips we packed on the root. Then, with a mixture, we plaqued the rest. No buccal bone, no palatinal bone, no interdental bone. A mucograft seal. Good. Then we get the bone back. Even though we use no membrane, it's just a good packing. Interproximal bone regenerated, not exactly the bony peak. So good. Now we're going to place the implant. It's an easy case. So in this case, obviously we do fully guided. When it's very complex, I want to control, sometimes partially guided. But always need a digital and analog guide, actually, what I like. Good. Now we do the different iceberg. We then take the mini tuberosity, slice it in two little pieces, deepitalize, take it two little pieces out of this, and suture on the palatinograph, but now interproximal. Okay? So this is the interproximal iceberg. Why is that? The triangle. Now, this is not enough. The closure you do has to be the papillary closure, which is a little bit like oblique vertical incision that is going to, vertical mattress suture is going to bring it down. And now you have to close it. I want to close it like nothing is visible. That's why I'm using here a 7-0 with the micro loop sutures. The micro loop sutures showing you much more aesthetic healing for the vertical incisions. Okay, that's good. And then just want to show you the iceberg. Look at that socket graft. I think the best socket graft I've ever done. And the iceberg and the papilla fully reconstructed. The bone fully reconstructed. Please read this article in the IGPRD. Okay, this is the final reconstruction, interproximal bone, and a very happy patient who was coming like this, ending up like that. Good. But what about this patient? But that's more difficult. Several bone grafts failed. That too doesn't look good. No, we clean it out, let it heal, and doesn't look very good. Oof, it looks bad. So I would love to save this. If it's a single tooth, I like to say I die first before I extract the next tooth. But this tooth, if I could reconstruct, that would be great. So what shall I do? Let's try. We do the extended safety flap because we may need the papilla shift. See, the papilla is completely missing. You're going to do bone grafting there. How are you going to close it? You bring it down? No, it's better to slide the papilla there. Okay, so now we're going to clean the root. What can you do on the root? Nothing. I think you should use something on it, like amelogenin. We use the PDGF. PDGF is not available everywhere, but I think it's a very good material on the root. And we also use the polynucleotides recently, which is easy to get. Anyway, this is the PDGF. On a dry root, it should get into the tubes. Now, also the autogenous chips, which we covered. But as you can see, we're not going for we're trying to go to the full, but not exactly the full cover. We also put the growth factor into the autogenous chips. The PTFE membrane, now it's getting too close, so we really have to cut it back. And then I'm going to have to do like a sausage on this denuded root. So sausage to me today is like used for all kinds of indications. Why do I put those little chips in here? I think it's just for support. And I put the growth factor into the collagen. Why? So it's communicating better with the periosteum. Now there's going to pin, stretch, microsuture, pin on the palate, and stretch. A sausage. We're going to close. Okay, the papilla shift. So this is what we do. And I have to say that I wasn't happy with the result. Very good healing. Result is acceptable. We covered some of the root, but we didn't cover it all. So what did we do? When I placed the implant, we placed a mini sausage on top of the implant on the interproximal, and you can see that this bone graft is very stable. This bone graft, we utilize the polynucleotides, the region past, because I think it helps, also the stabilization. Now we do the sausage on the top, and this is, how it was still. The sausage on the top, now how did we do it? Like some chips on the root, the implant, in between the implant, on top of the implant, and the sausage. Okay, so both patient goes home. Patient comes back. This is a partial thickness flap now, because now we're not going to do any more full thickness. X-ray, CT scan look pretty much perfect. Okay, we're going to do a partial thickness flap. We do a big piece of connective tissue graft, either an iceberg, but this was one beautiful piece. I didn't need an iceberg. Okay, again, and we use empirically polynucleotide, gel, hyaluronic acid to help maybe soft tissue healing. And I thought I had here the CT scan, but I don't. But anyway, so it's pretty much to perfection, this bone graft. Okay, look at this one. Yeah, this is a defect before and after, interproximal iceberg. But here, in this, the previous case was went almost to a full regeneration. This one did not. I mean, it's still oblique. It's still a very big piece of connective tissue graft, the strip graft. And we're going to have a good result because the tooth didn't have any bone up to the apex. Health is perfect. No probing on the tooth. Implant is doing very well. It's a final abutment on the implant, a final abutment, like an N1 abutment on the implant. And I think this popula is still going to grow down. Patient's very happy with this. And I think it's a very good result, relating to what the original was. So, and here's another region, okay, for 10 years. Here's another region. I showed the, follow-ups on the anterior, but also like this posterior maxilla 20 years later. I would like to pinpoint Dr. Cookie's article. Dr. Cookie published the paper, What Happens to the Bone After Vertical Ridge Augmentation? The blue line is guided bone regeneration. I'm not going to mention the rest, bone blocks, this and that. Guided bone regeneration seems to be very well documented. The good thing is there are studies from short, middle, and long term, and the continuity studies too. And Dr. Merli, I would really like to mention. I think he did a very beautiful study on this. Follow-ups. Here's another one, just posterior maxilla 10 years later. Okay, so what we can do is, basically these techniques, I think they're simple. They're repeatable, and most importantly, they're biologically sound and less invasive and not overcomplicated. Simplicity is sophistication. And that gives you, I think it has the lowest complication rate according to literature, more predictability on the final outcome. And so with this, I'd like to thank you very much for the attention. And in this presentation, I showed some of the cases that I had before also, some of the cases that I'm having now. And I showed some cases, in a different perspective. And I hope you enjoyed this lecture. Thank you very much.